Welcome to our case review series. Today we will be talking about saving teeth with internal and apical resorption. I want to start by thanking our sponsors, Colteen, Oral Arts Dental Laboratories, and Romero Dental Seminars for making this case review series possible. I also want to promote our YouTube channel, Romero Dental Seminars. We have over 120 videos that have been uploaded, and they are all free for you to watch. All you have to do is choose your topic and sit down in the comfort of your home or office and watch and gain a lot of insights on different dental topics. And there's a couple of interviews also that we've had throughout the years with different specialists in different areas. So I know that you will enjoy our channel. Please make sure to click on the bell and the subscribe button so that you can get instant alerts every time we upload a new video. Our objectives for today are going to be understand why we would consider saving a tooth with internal and apical resorption, learn how cross-polarized photos can help, and highlight the steps for a single anterior tooth highly aesthetic composite veneer. So let's get started with our clinical review number 1. Understand why we would consider saving a tooth with internal and apical resorption. And one of the things that I want to share with you today is that personally, I always look at the age of the patient. And I also consider other areas or other topics that are also very important. Like, for instance, the smile line. Is it a high smile line, a low smile line, an average smile line? What are the aesthetics of the patient? What is the overall oral health of the patient? Does the patient have multiple restorations? Does the patient have no restorations? All these things, when you put them together, for sure they're going to make they're going to help you decide what is the best way to treat these cases. Now, for this particular patient that I'm going to share with you today, one of the things that really hit hard for me when I was reviewing this case and see how I can help this patient was her willingness to try to keep this tooth. She wanted to keep the tooth. You can see that she has a high smile line, very, very beautiful teeth, and a very highly aesthetic case. If you think about extracting the tooth that we're going to be working on, and the tooth that has the internal and apical resorption is tooth number 9. And if you look at the photo, most likely this was due to a fracture. She had had a previous class 4 restoration done many years back, and so the tooth had trauma in her short life because she's a very young patient. And at this point, she had gone through orthodontic treatment, and she wanted to try to, again, save the tooth, preserve it as long as possible, because she knew that eventually, if she would have to lose the tooth, this tooth would need to be replaced with an implant. And when you look at these small photos and you look at the lip, how high that lip goes, how high her upper lip moves, and shows or displays this pink aesthetics for her, this high smile line, you can see that if for whatever reason this at the moment of the tooth extraction, the tooth was ankylosed, at the moment of extraction and implant placement, how easy would have been for any periodontist or any oral surgeon or any implantologist or any restorative dentist to try to reproduce exactly what she has, try to maintain that gingival zenith for tooth number 9 exactly where it is. So these are all things that you have to put into consideration when you are considering a treatment plan for a patient like this. In second place, I also consider the age of the patient. If the patient is young, I want to try to defer as much as I can the placement of the implant, because we all know that implants also can have their problems of their own, and any problems that can be prevented early on, or any problems, I'm sorry, that we are going to be confronted with in the future of the implant may create some recession, may create some issues around the tissue that are going to be very visible every time this patient smiles, again, because of her smile line. So all these things, again, we have to put into consideration, and I put them in consideration, talking with the patient, knowing that she wanted to save the tooth, knowing that she wanted us to do the best we can to try to save the tooth. And this is where comprehensive care really comes into play. Of course, we have to consider a periodontist and, most importantly, an endodontist to see if it was still, the tooth was still at a point that we can at least give it a try and try to maintain her in her mouth at least for 10, 15, God allow us, even 20 years down the road. We don't know how long this is gonna be there, but we knew that the tooth was very nice and stable. The tooth wasn't mobile. The tooth was actually ankylosed. And when you look at the X-rays, you will see what this entitled. This at this point, this photo was taken after the root canal was completed. After the root canal was completed, there was also a small flap that was done by a periodontist on tooth number 9. This photo was still healing. You can see there's a little bit of an area here, right in the mesial gingival aspect of that interdental papilla. There's a little bit of healing still going on there. This photo was taken when that healing was going on. She had had a flap there done because there was a small perforation on the buccal root surface that they had to access, and then had to restore that area with a special biomaterial. J-Restore was actually what was used by the endodontist. The flap was done by the periodontist, but the actual repair of that perforation was done by the endodontist. So again, a lot of things done for this tooth. You can see a little bit here of that of that surgery that I'm referring to, when the endodontist wanted to repair that perforation that had been done on the buccal aspect of the root surface. You can see that they're going in, they're going to do a little flap, and then they're going to access that area. They're going to fill that area with J-Restore. They're going to smooth that area nicely, and then they're going to go ahead and reposition that flap exactly where it was. There you can see that they've already restored the perforation with the J-Restore. Now they're just polishing that area. All this, again, this is what multidisciplinary care is all about. And again, the patient informed, the patient understood where were the risk of going through the process of trying to save this tooth, but she was willing to take the risk because, again, if we knew that the tooth was ankylosed and that the tooth was nice and stable within that alveolar process, so all we needed to do was to be able to seal all these perforations. Everything was restored internally. It wasn't done with gutta percha. It was done with MTA. They seal that apical resorption. They seal that apical access with the MTA, as well as in this root surface. Only on the buccal surface it was restored with J-Restore on the perforation, and on the lingual the access was actually restored with composite resin. So a combination of procedures, a combination of dental materials, but you can see the ultimate goal was to try to give this tooth a chance. I know that many of you out there will probably will probably see this case differently. You probably would decide to extract the tooth at this point and place the implant or do the bone graft. And I'm not saying in any way, shape, or form that it would be an incorrect procedure. I do consider that it would be an aggressive treatment option for the age of the patient, for the high smile line that I was considering. I would definitely defer the implant as much as possible. But again, what we're trying to do here is not to discuss what option would have been better, but just to kind of see or review a very conservative option for this patient. So my second clinical review is going to be I'm going to help you learn how cross-polarized photos can help you for a case like this. And this all has to do with aesthetic dentistry. Again, when you looked at the cross-polarized photo, what I'm trying to see is I'm trying to evaluate the aesthetic aspect of tooth number 8 so that I can replicate that on my composite on tooth number 9. And the things that I want you to see is, number one, you can see that halo, that darkness that the actual tooth had on the cervical third. And that darkness has to do with a very thin enamel because there was a lot of resorption in that area. And what you're seeing underneath is the translucency of the different biomaterials that were used to restore that area of the tooth, the MTA, the composite on the lingual, the J-Restore on the cervical. All these materials now have created that halo, that transparency or that translucency effect in that cervical area that now differ from that very high value white cervical third located on or that is seen on tooth number 8, and that's what we have to try to replicate. So right there, then I can tell you that I'm going to have to most likely place a very thin, opaque dentin in that area so that I can hide or mask that area. The other thing is that I want you to look at the middle third of tooth number 9 and compare the middle third with the middle third of tooth number 8. There, I barely have to do anything. So I can just get away with probably just using, whatever shade I choose for dentin, I'm going to be able to layer in that area. And the only area that I'm going to have to come back and layer and look at the way that I'm going to create that halo effect is on the incisal third. And you can see that the incisal third of tooth number 8, you have the white halo on the incisal edge, you have the mammalons well defined, you have a little bit of gray translucent, you have a lot of white spots. So there's a lot that I'm going to have to, try to recreate as best as I can when I restore that single veneer for tooth number 9. And that's what becomes really a challenge. Could I have had the opportunity to do a ceramic veneer and try to ask the lab to recreate all this for me? Yes, and it would have been the same type of challenge. It's very challenging when you look at restoring a single anterior tooth, and we all know that. So for me, the composite veneer was a really good option because, again, eventually this tooth is going to be lost in 5, 10 years. We don't know. But the other thing is that it's a lot easier to maintain. If the other aspect that I also analyze is that if I miss for whatever reason the perfect shade or the perfect shade combination for my final veneer, it's a lot easier for me to remove and redo that restoration compared to a ceramic veneer. But both options would still be a good option because if you look at this photo, you can also tell that tooth number 9 is a little bit more lingual. And the reason for that is that this patient went through orthodontic treatment before the trying to save, before the endo procedure and the perio that we did on tooth number 9, she went through ortho, and because the tooth was ankylosed, the tooth was left more lingual. That was the actual position of the tooth. Well, this at the end of the day ended up being, something good for me because now I don't have to remove any of that enamel. I can actually bond. I have to add more material to restore that tooth to the right buccal contours. So that helped me be more conservative. Helped me not have to remove any enamel. And most likely and most importantly, on that cervical third, where I already knew that the enamel was very, very thin, and I had no dentin underneath that area, because again there were multiple different restorative materials that were underneath that enamel in that cervical area. So this is how I use that cross polarized photo, because it helps me understand what kind of substrates I'm going to have to replace, where to use more opacers, where do I need to use a very flowable opaquer so that I can hide anything that I need to hide. So this is what it helps me do. It helps me kind of create that map. And now what I'm going to do is I'm going to select the restorative material. For this particular case, I chose to use Mirrors 2 from Coltine, which is an outstanding, highly aesthetic, restorative, direct restorative composite material. And that's what you're seeing here. I have the OBL and the BL trans. I'm looking at these opaque bleach shades on the cervical third. I want to use that BL trans. These were actually part of the Brilliant Ever Glow system. And I was trying to use different systems just as you wanted to show you, how I go about choosing the shade and choosing the right material. So for this particular case, I actually ended up choosing, I'm sorry that I said the Mirrors 2 at the beginning. I actually ended up using Brilliant Ever Glow from Coltine. And there you can see the OBL and the BL trans that I was just trying to shade match and see which one would be the best combination in order for me to restore this tooth. So my clinical review number 3 would now be, highlight these steps for a single anterior tooth, highly aesthetic composite veneer using this Brilliant Everglow system, combined with some flowable intensifiers. Also, these are also made by Coltine, but they're part of their Mirrors 2 system. So it's actually a combination of both. So the first thing that I did was actually do a digital wax up, and this digital wax up was done just out of a scan. You can see again the lingualized position of tooth number 9 compared to tooth number 8. So I went ahead and I added a little bit of I added a digital tooth onto that site, and that gave me that bulkiness that I needed towards the facial. Once I placed that digital tooth on my scan in the right position, I went ahead and 3D printed the model, and out of that 3D print I created a lingual matrix, and that is what I was going to use in order for me to get the right length and the right incisal edge anatomy and location. So here I'm trying that OBL. Again, I'm just trying to make sure, is it enough opacity for this material in order for me to recreate that opaque area that I need on the cervical third? The answer to that question was no. So I decided to actually add underneath the OBL a very thin layer of an opaque resin, again made part of that Mirrors 2 kit made by Coltine. So after isolation, I'm going to go ahead and make sure that all the line angles of the fracture area of the tooth after removing that old restoration were nice and round. I don't want anything sharp. There was no enamel reduction. Again, there was no need for it because the tooth was slightly more lingual. So now I'm just going to go directly and etch this enamel. And because this enamel was not cut with a burr, I'm going to increase the etching time. So I'm going to etch for 30 seconds instead of 15 seconds. I have a very high fluoroapatite type of enamel that is more acid resistant. So that's the reason why I'm increasing the etching time. I'm going to then rinse after those 30 seconds, dry the tooth, and you can see bone dry the tooth. Very nice and a very nicely etched enamel all around. Really, really good substrate. Very, very easy to bond to and very predictable bond to this for this substrate. So here you can see I've placed now my adhesive layer. I'm using my adhesive, and all I'm doing is just placing that very thin layer of adhesive from the cervical all the way down to the fracture area. I want to make sure that I do that, protecting the neighboring teeth, and normally I have a mylar strip when I do that. And then I'm going to go ahead and use my lingual matrix and an explorer to mark exactly where that lingual matrix meets the fractured tooth surface. And the reason why I do this is that when I apply my composite onto the matrix and then into the mouth, I want to make sure that that first lingual layer actually contacts at least half of a millimeter of a little bevel that I created on the lingual aspect, so that I know that the resin is actually in contact with tooth structure, with enamel on the lingual surface. So here you can see if I've applied that first layer of enamel, and now I am just condensing that enamel, just making sure with a very small spatula, making sure that there are no bubbles, that the enamel is now touching, the enamel and the composite are coming together. And this is again the BL trans, that's the enamel that I chose to use for this case. Once I have that, you can see that I've created the ideal length, the correct distal embrasure, and the correct mesial embrasure also. This is now, because I don't want to overdo this, I don't want to make this tooth longer because there's so much aesthetic aesthetic layers, clears and white opaques and mamelons and everything on that incisal third, that I don't want to have the need to create a very long tooth and then cut back and end up having less than what I really need, or even more than what I need of those effects in that incisal third. So starting out with the right length is always ideal. Here I'm placing, as you can see on the cervical third, I've placed that opaque layer, flowable layer of composite, so that I can hide a little bit of that translucent area that was created there because of that thin enamel. And now I'm going to start placing my dentin. And my dentin, again, I'm using the OBL, which is an opaque bleach shade. And with that opaque bleach shade, I'm going to start repairing that fracture area first. That's the first area. I don't want to have any voids there. So I always like to add a little bit of composite there before I start building up my mamelons. Here I'm adding a little bit of that same flowable opaque that I use on the cervical third. I'm adding it in the incisal third so that I can recreate that halo that I showed you in that cross-polarized photo that I showed you initially, so that when we were evaluating the aesthetic aspect of this tooth. Now I've created those mamelons, again using that that OBL bleach, that OBL dentin, which is the opaque bleach dentin, and I've created now my 3 mamelons. I've left a little bit of space in between those mamelons so I can add a little bit of blue or a little bit of gray that is part again of that Mirrors 2 kit that is made by Coltine. I've added a little bit of blue there as well so that I can recreate a little bit of that translucent effect that I had on that incisal third. Now I'm starting to build that composite, again going with that opaque composite on the cervical third. I'm literally using opaque bleach shade all throughout the restoration because she had a really high value, very high value enamel, very light teeth. She had bleach, I would say, excessively, and that's something that you always have to be careful with when your patients are bleaching. Make sure that they don't bleach too much, because if it's too much, it's going to be really a tough time for you if you ever would need to do a restoration. Like in this case, you're going to have a really tough time trying to match that shade. And we really had to look through different systems to try to find the right shade for this particular case. So now you can see that I'm now building that middle third, again using the OBL dentin from the Brilliant Everglow system. We're coming down. You can see that we've already achieving that very high value enamel. And then at the end, we're going to place our final layer of that bleach translucent from the same system, Brilliant Everglow. Now this bleach translucent, don't forget, you want to just have maybe half of a millimeter thickness of this enamel layer. If you use too much, you would end up with a very translucent, very kind of grayish type of tooth. So you want to make sure that you use, because we knew that she had a very high value, we wanted to make sure that we had enough OBL, enough dentin shade, very light shade, so that we just have a very thin layer of enamel. And again, half of a millimeter, no more than that. That's what you're looking for. We did the mesial mylar pull technique, the distal mylar pull technique. I'm not going to talk about the specifics of the mylar pull technique. I have another video. I have a couple of videos here in my YouTube channel that you can just go back to and just watch these videos where I'm very going into details of this mylar pull technique. One that comes to mind is a webinar that we have on composite veneers restorations. You will watch me do that live on a page on a dentiform, how to pull the mylar to the mesial and to the distal to recreate these line angles as you are seeing here. And then finally, we just do our final facial increment. And once we do that final facial increment, we are done with our restoration. Once we're done with our restorations, again, we always end up with a little bit more than what we need. We remove the rubber dam and we start our finishing process. I can't recommend you any other finishing system more than Softflex. This is the one that I like and I love and I use. I've used other systems, and there are other systems out there. Actually, Kerr makes one that is also very nice. But honestly, I just haven't found one that I like more than the Softflex system. And I only use the coarse and the medium disc. Everything else is going to be done with burrs, specifically the 8888 diamond burr, and then polishing directly with a shape guard that is also made by Coltine. Again, I have another webinar on finishing and polishing composites that you can watch, and you will see me do it step by step. I'm not going to talk about that specifically here, but that's what I'm doing. I'm just going into finishing and polishing. I'm going to use the Epitex also to get into my inner proximals. This is a very thin, beautiful diamond finishing strip made by GC America that I also love. It gives you this very nice and smooth finish without removing your proximal contacts that you've worked so hard doing, with your mylar pulls to kind of to accomplish. So this is another good thing that I tell you. And then finally, I'm going to definitely go in with my shape guards, which is a two-step polishing system, pink and blue. The pink is just to get you that nice smooth surface. It does remove a little bit of your composite, so just make sure that you don't put a lot of pressure. I would say just stall speed, 250 to 300 RPM underwater with light touches, and then you move forward with the blue. The blue is going to give you that high shine. It's going to make you get that nice and high luster. Now, the luster is going to be based on how much shininess does the patient have in their neighboring natural teeth, and that's really what's going to make you accomplish either a very extremely high shine or just medium or moderate high shine. With is normally the case for many of these of our patients. And you can see here, this is immediately after. Of course, it's not a good time for us to evaluate the value of the restoration, but you can see that we've been able to recreate, not only to recreate in regards to shape and form, the actual shape and form of tooth number 8, but you can see that we have the same gingival height of contour and the same halo effect on the incisal edge. We do have to wait at least, a day or two. Sometimes, I normally see my patients in a week or 2 weeks for me to evaluate the case, because that's really when you're going to come in and you're going to be able to evaluate value. Right now, the other teeth are dehydrated. This case took me at least an hour to layer everything and to finish. So all the other natural teeth are dehydrated. This is definitely not the best time for you to evaluate the final color, but you can definitely evaluate is the shape of the tooth, the smoothness, the way that we've recreated all the, the developmental grooves and all the halos and all the effects that we were trying to recreate. There are there. I know that this tooth ended up being, just blending in with her smile, and this restoration is still in function. I would say I think it's maybe 3 years after it has been completed. And I know that, I've seen some photos of this patient after the restoration. I've seen her smile and just blended in nicely. But the most important thing here is just the conservative nature of this particular a protocol, and the also the conservative nature of the thought process behind the case. What is it that we're looking for as clinicians? I'm a clinician that have been doing this for 29 years. I consider myself that I have a lot of clinical experience because I've seen a lot. So the more you see, the more you're going to gain that clinical experience. But I'm talking to those younger dentists out there that watch our videos. You want to always try to give teeth a chance. Believe me, these teeth, they really are very resilient. And this patient is a very healthy patient. And again, just look at the first portion of this webinar, of this clinical case review, and just listen to what I said. You have to think about everything. Don't think that the solution for everything that you're going to do is going to be an extraction and an implant, because sometimes that is just too radical and may take you through routes that are not really the ones that you were looking for, and outcomes that most likely are not the ones that your patients are looking for, and they end up getting you into trouble. A case like this, I wouldn't feel comfortable doing either the extraction of the implant placement. I would definitely feel comfortable working with a very knowledgeable and very experienced periodontist that can help me do something like this. But this is not the time for this patient, and this is what this case is all about. So I really, hope that you enjoy watching this video, enjoy watching this clinical case review, and I hope that you can take some of the points that I've tried to make today to your practice, so that it can help you also deliver care for cases that you may have like this in your own clinical setting. Thank you for watching, and hope to see you during our next clinical case review.